All right. Thank you, everyone, for tuning in, whether you're watching on YouTube or listening wherever you get your podcasts. This is the Scoliosis Dialogues, the official podcast of the Scoliosis Research Society. I'm Grant Hogue from Boston Children's Hospital, and today we're doing an article spotlight from the latest issue of Spine Deformity. More specifically, we're going to be discussing the article 30 Years Later, the lingering effects of AIS surgery with third-generation implants on quality of life. And we have the senior author here, Dr. Ferran Pellisé. Thank you so much for being with us here today, sir.
Thanks so much for inviting us to participate in this podcast and be able to explain further the paper we published in Spinal Deformity and was presented at the annual meeting, I think, 2 years ago.
Excellent. And so if you wouldn't mind, for anyone who's not quite up to date with the journal, maybe they're a few issues behind, could you give us just a quick overview of the paper?
Yeah, so the idea of the paper was basically when all the new technologies and basically fusionless techniques were appearing in the market, we thought that these techniques should be compared to the gold standard. And many of the long-term studies had been done with Harrington instrumentations. And obviously, this was not comparable to what we were doing today. So we thought there was a good opportunity to understand and see how the patients operated with, let's say, modern or third-generation implants were after a, let's say, long-term follow-up, minimum 25 years. This was the original idea and why we did the paper and the research.
Excellent. And so this study, just as you mentioned, has a very impressive range of follow-up. And I think the average is 31 years. And so for you, what were the biggest challenges in tracking down patients and collecting data from this cohort?
So this study was, we started this study together with the hospital in Madrid, La Paz. We have a long-term and very stable and productive relationship with them. And we have a good database of patients that were operated between 85 and 1995. So we tried to see if we could reach them and try to do this cross-sectional study. And this was probably the most difficult part of the study because it was difficult to get the addresses to reach the patients and ask them to participate. Some of them had to travel. They were living in different places. They were now mature adults. And this was probably the most challenging phase of the study. And this was done basically by the first author, Antonia Matamalas, who is now leading the spine section in Girona, very close to Barcelona. And at that time, she was working with us in Barcelona, and she had been our former resident and fellow.
That's really incredible, because research on its own is hard enough, but research, as well as almost being a detective to find patients, is really an added layer. And so you really assess a few different outcome measures here, but it's interesting to me that you're looking at the SRS 22, a disease-specific questionnaire, along with kind of general health surveys like the SF-36. And how important do you think it is in long-term studies to use both of these, whether you're looking specifically at disease or general health?
This is an extremely relevant question. So the idea here was trying to see how big is the gap between our operated patients and, let's say, the general normal population. Because new technologies are here just to improve and reduce that gap. So we thought it would be interesting to measure how big is the gap between the patients treated with CD or third generation and general population, and then have this data to be able to compare later on the new technologies, fusion preservations, to see if they are really reducing the gap that we have between CD and general population. So to have the data for general population, you have two options. You can go to normative data of these general outcome measures, and this is SF36 and the EQ5D. And the other option is going into national public databases of general population and get general health information as well to compare with the scoliotic operated patients.
That's excellent. And so, for any listeners or members of the SRS who aren't surgeons, or maybe who are young surgeons, and are not aware of the differences between classic Harrington instrumentation and the CD instrumentation system, what makes this a third generation, or what makes it different than what we were doing before?
Excellent question as well. So Harrington instrumentation was extremely prevalent between the 60s and the late 80s all over the world, and correction of the deformity was done basically by distraction. So the limitations compared to the third generation instrumentations is that the percentage of correction was clearly lower. Sagittal plane was not taken into account, so it was basically coronal correction. Then the stability of the construct was extremely low or not as good as third generation. So the risk of mechanical complications were high, and patients were treated also with external supports, either plaster or braces, and many cases they had to resume bed rest for a long period of time. So the third generation implants were providing better correction. They were providing multiple anchors. They were very segmental, and they were taking into account the sagittal alignment, and this was very good. And also they were providing enough stability so to be able to mobilize the patients very early without need of external support. So this made a big difference.
I think that's such an important point to make, that even at the most simple levels, moving into segmental fixation and the realization that you can affect the sagittal plane in a positive or a negative way was a shocking difference from what had been going on beforehand. And so in that regard, as we get into your results, one of the things that you found were patients with better postoperative thoracic correction had higher patient satisfaction. And so within that statement of better postoperative thoracic correction, is that a coronal plane, a 2D measure, or is that including the sagittal plane as well?
Good point. This was considering basically the coronal correction of the deformity. Now this study was resulted from a young investigator research award at SRS. So it was the origin of and the pilot study, and based on the data we got here, we applied for the first SRS directed research grant, and we were awarded with it 3 years ago. And now we are collecting data from multiple continents and multiple hospitals. And we already closed the study. We have 550 patients with more than 20 years of follow-up from Asia, from America, basically coming from Washington University, from Europe. And in these patients, yes, we are now measuring the sagittal contour and trying to see how close they get from normality based on PI.
Excellent. And so were there any findings within this study that specifically surprised you or surprised the research team, things you weren't expecting to find?
So I think the results of this study showed that patients with scoliosis treated surgically, they get closer to the normal population with the operation, but there is still a small gap. And this gap is quite minor in 60% of the population, but it's still very relevant and mostly in terms of pain and function in approximately 20% of the operated patients. So there is clearly room for improvement here. And this is what we should now understand and try to solve. We did another study which was presented last year in Barcelona using this same cohort, trying to understand which were the predictors of worse outcome in this cohort of patients. And this was basically linked to lumbar MRI findings, basically degeneration, lower instrumented vertebra, sagittal alignment, and number of unplanned reinterventions following surgery, following index surgery.
So one of the things that you mentioned is the gap between operative patients and the general population. And obviously, all of these patients had surgery 25 years ago or further. And anyone who has read the Spine Deformity Journal has seen so many of your papers, a lot of which have to do with cohort analysis and trying to find out how someone's going to be doing 20 or 30 or 40 years from now. And so with our current understanding of scoliosis as a 3D problem and our current instrumentation, how close do you think we are to closing the gap? So if we looked at today's cohort 30 years from now, what are we going to be telling our patients?
Excellent point. So this was basically the main goal of this study. So I think we are doing better. We are doing better because this cohort of patients, the one included in this study, they had a third generation implant systems, but we were instrumenting spines mainly using hooks, and no screws were used above T10. So I think now we get better correction. We are better stabilizing, and we have less loss of correction. We have less complications. I think the number or the rate of unplanned reinterventions will be reduced, which is part of the problem. We are also improving. I think we are restoring better the sagittal alignment of the thoracic spine and therefore of the lumbar spine as well. And basically, I think we are clearly much better, and we have understood the relevance of the lower instrumented vertebral level. So we are now saving more motion segments than we used to do 25 to 30 years ago. This cohort of patients, approximately I think it's, let me check, but I think it's below 50, but 47% of the patients were instrumented down to L4 or below. And this now is not happening. So saving motion segments, improving the stability of the construct with pedicle screws, improving the correction, and reducing the overall rate of unplanned reinterventions should close this gap. The question is, are motion preservation instrumentations or systems closing this gap even more because they are more normal? Are we really normalizing more the spine? Or, which is very relevant, the number of unplanned reinterventions will clearly reduce the gain obtained with the correction, because we know unplanned reinterventions do have an impact in the overall result and outcome at 25 and 30 years of follow-up.
No, I mean, that is absolutely spot on. And so, Dr. Pellisé, if there was anything that I would say about your research program that sticks with me. It's that I feel like you very much have benchmarked the past for us to help us continue to predict the future. And we are all indebted to you for that. And we very much appreciate you coming on the podcast and being part of the Scoliosis Research Society and part of the Scoliosis Dialogues. Are there any final thoughts that you have related to this project that you want to share with our listeners?
Yes, I think I want to mention something. This study has been possible because two high volume units in Spain have walked along for many, many years and have had an excellent relationship. This was generated by my former boss and clearly my mentors, both in Madrid and Barcelona, Paco Sanchez. So I want to acknowledge here Paco Sanchez and Carlos Villanueva for generating this trust between the two units, having these databases at that time. And I also want to acknowledge the work done by Javi Pizones, who's been extremely good in that, and of course of Antonia Matamalas and Juan Bago, who have been extremely relevant for all the results we are presenting and all the research we've done over the last years.
Absolutely. Research is a team sport, and it doesn't work without the team.
Exactly. Right.
So thank you so much once again. As we get ready to close this out, I want to remind anyone who's listening that registration and housing are both open for our SRS annual meeting. This year, we will be gathering in Charlotte, North Carolina, and the meeting's from September 16th to 20th. So I hope that we see you all there. Dr. Pellisé, I certainly hope I see you there.
I'll be there. Thanks very much for the invitation. Thank you.